to the demo.
This was really good.
Do you know what this is? Well, this is not a transthoracic echo, it's a TEE, but I guess you can still make the diagnosis. This is a case of aortic dissection.
And this brings us right to the topic of this chapter, the aorta. Now, the aorta is part of the heart, and with echo you can image the aorta. So don't forget that we should diagnose diseases which are not so infrequent, such as a dilated aorta or an aneurysm, as it is also called. The definition of an aneurysm is an outpouching of the aorta where we have a width of more than 4 centimeters, and it has a considerable morbidity and mortality. But where do we find such aneurysms?
Well, most of them are located in the aortic root and ascending aorta, so 60%, while 10% are in the aortic arch, 40% in the descending aorta, and 40% in the thoraco-abdominal portion. And here are some facts about aortic aneurysms. The risk factors are hypertension, connective tissue disease, or bicuspid valves. And the risk of dissection is really high when it's related to connective tissue disease and increases with the diameter.
Yes, and the diameter is very important because the increase in the dilatation of the aorta depends on how large the aorta is. So the further you get in this region of the curve here, the higher or the more rapid will be the progression of aortic dilatation.
And the diameter of the aorta correlates with the risk of rupture. So for instance, if the diameter is between 40 and 59 millimeter, the risk of rupture is 16%, but goes up to 30 and more percent when you have more than 60 millimeter of aorta.
And here are some facts. Well, approximately 2.6 to 3.5 per 100,000 population is the incidence of aortic dissection. It occurs more in the elderly population, so if you're above 60. And hypertensive heart disease and atherosclerosis are risk factors. So if you have someone who has peripheral artery disease or coronary artery disease, those are the ones you really have to watch out for. And finally, 13% have aortic aneurysms.
And moreover, if you have aortic dissection in a young person, this is more commonly related to connective tissue disease, but it could also be related to inflammatory disease, often to bicuspid valves, or it can be also iatrogenic, so during, for instance, a cath study.
So from what we've said here, you will understand that there's a very close link between dilatation of the aorta and dissection.
But Thomas, at the beginning of this course, we showed a CT image together with a TE image of aorta. But which imaging modality would you use to assess the aorta?
I think both, Anna. I think both have its role. First of all, it depends on how acute the situation is, and it depends on what you're more familiar and what you have available. But definitely echocardiography has a role. But let's first turn to some beautiful images that we can generate with the help of CT and even MRI. What you can see here is you can see the entire aorta very nicely. You can reconstruct the images, and sometimes for confirmation, we need to do both imaging modalities. But when we come to echocardiography, I think one of the major advantages is that we can suspect dissection already from a transthoracic echocardiogram, and we can see things, for example, such as here on the left side, where we have a dissection membrane, and we can see the entry site and even the extry site of a dissection. So these are advantages that we have with echocardiography, and we're quick. We can perform the echocardiography on the bedside and even on the intensive care unit without bringing the patient to the CT, just plug a TE probe in and look at the aorta.
And even when using ultrasound, we can actually use a transthoracic approach or a transesophageal approach, intravascular ultrasound, and also abdominal ultrasound. But this course will deal with TTE and TE mainly. And when we consider a transthoracic exam, actually we can see several segments of the aorta. We can really well visualize the ascending aorta and the root. We can see the arch, and we can even see parts of the descending aorta. But I guess this is easier to understand when we go to the simulator. The aorta leaves the heart in a really strange fashion, and the simulator is optimal to show us this. Look, when we are imaging the heart from a personal long axis view, we can see the first part of the ascending aorta because the aorta goes from left to right, but the first portion comes anteriorly and then goes cranially. So actually, when you follow the anatomy, here we see the aortic root in the annulus, sinuses of valsalva, and sinotubular junction. Then we see the aorta. And the simulator shows us the aorta goes into the arch and again down, taking the name of descending aorta. So the simulator is really showing us this. In real patients, it's not so easy. Actually, you need another view to see the arch, but this is advanced, and we will show you in the master class. For now, I'll show you other views where you can appreciate the descending aorta. Here's the first one, still parasternal long axis view in the short axis, right posteriorly to the left atrium. And when we go to the four-chamber view, apical, here it is again, descending aorta lateral to the left atrium, and in the two-chamber view, we can appreciate the long axis of the same portion of the aorta just by tilting the transducer a bit. And here it is. So actually a few views which allow you to recognize different segments of the aorta.
Beautiful demonstration. Now let's take a look at some pathologies. Here on the left, we have, as you probably all already appreciate, a normal aorta, and here a definitely dilated aorta. You see that the area of the valve is pretty much normal, but then the whole root of the aorta is dilated. We can't see very much of the cranial portions of the ascending aorta, but definitely we can diagnose a dilatation. Now this is the same patient in a short axis view, and now we also understand why the patient has a dilated aorta, simply because he has a bicuspid valve. And remember, bicuspid valves are frequently associated with aneurysms. Here's another example. Again, a patient who has a dysfunctional aortic valve. It's probably also bicuspid and a little bit thickened. And this time the shape looks a little bit different. We can see that the aortic root is pretty much normal, but after the sinotubular junction, the aorta is dilated. See how we image the patient so that we see very much of the cranial portion of the aorta? Well, the aorta can be imaged from several views, as Anna already mentioned. But we can also view it from a very atypical position if it's dilated. We can just go to the other part of the sternum, to the right part of the sternum, and image the aorta there as well. This only works, however, if you have dilated aortas.
And let me now show you where to measure. I would measure at the level of the aortic annulus, then at the level of the sinuses of valsalva, which here is not really distinguishable because extremely dilated, as well as the sinotubular junction, and 1 centimeter above for the ascending aorta.
I think the ascending aorta is probably better visible if I just go up one intercostal space, and here you see very nicely how dilated this aorta is. It's 7.6 centimeters, and remember what we said with the risk of rupture, this is probably a patient where you will agree that has a very high risk of rupture. Is it really necessary to measure all these parts? Well, I would say not in all patients. If it's normal, of course you will not do that. But in certain situations, as in this patient, I would, because it also describes the shape of the aorta. Now, if you image the patients from an intercostal space higher, you will get more of the ascending aorta. And if you see that the dilatation, of course, is more above 1 centimeter of the aorta, then of course you would measure there. So try to also measure the maximal diameter that you see. Now, one question that I know we're going to get is, where do you measure and how do you measure with echocardiography? Because you've got all this confusion about leading edge and outer diameter or inner diameter. Well, the leading edge method is something that we started doing when M-mode came about. I think now that M-mode is not the method of choice anymore, we have to move away from this technique. And this is something that is slowly sinking in to the guidelines of the various associations. So what I think is the best way to do it is to use the inner diameter, because with the inner diameter you will get a little bit less diameter as with leading edge, and it correlates better with the CT measurements.
But the parasternal view is not the only one to see the aortic vessel and valve. We can also use the 5-chamber view. Here it's not good to measure because the aortic vessel actually is coming towards us, so we are not cutting it orthogonal but somehow diagonal. And this is also the reason why we cannot distinguish the wall of the ascending aorta, but still we can recognize and differentiate a normal aorta and an aneurysmatic one. And for sure, a 5-chamber view together with a 3-chamber view will be really good for to assess aortic regurgitation, which is usually associated with aortic dilatation, as we said many times. So use the parasternal view together with the apical approach, 5-chamber and 3-chamber view. And now that we've seen the proximal part of the aorta, we will move to the arch.
For the aortic arch, you need to use a view that we learned in the chapter on aortic regurgitation, namely the suprasternal view. So we point the transducer downward towards the aorta, and that's where we'll see the aortic arch. Now, this is a view that works best in young individuals. In elderly patients, it's sometimes a little bit more difficult. But what you see is, you see the aortic arch here with the ascending aorta and then the descending part. And here we can also measure. We would measure, for example, here or here, and sometimes we're even able to measure parts of the descending aorta. So this is the view that we will get. We would have the aortic arch right here again with the ascending aorta, the arch itself, and the descending aorta. I think you can really appreciate that it's possible to detect dilatation here as well, and sometimes even dissection, because actually this region here is kind of a predilectation place where you would frequently see dissection. Okay, now from the aortic arch, we need to move down a bit and look at the last segment of the aorta that we can see, which is the descending aorta.
Yes, and the descending aorta we can actually recognize also in our standard views. For instance, in the 4-chamber view, apical approach, here it is. It's this round structure just next to the left atrium. And the same thing we can see, but it's in its length, in the 2-chamber view, just by tilting the probe more caudally. With this movement, we lose the left atrium, we look more posteriorly at the descending aorta in its major length. So, just for a review, we can look at the descending aorta in the apical 4-chamber view and 2-chamber view.
And sometimes you will see pathologies there. Of course, transesophageal echo has a much better imaging resolution, but sometimes you'll see aneurysms there, and I've even detected dissections. So keep that in mind. This view is an adjunct to looking at the aorta. And to summarize, there's also the parasternal long axis view, where you can not only see the ascending aorta here, but also the descending aorta close to the left atrium. So if we put all this together, parasternal long axis view, the aorta here, 4-chamber view right here. Sometimes it kind of even indents a little bit the left atrium if there's some degree of kinking. And then the descending aorta here in a 2-chamber view.
And are you ready for some examples? Here, for instance, can you detect the structure which is abnormal? We said in the 4-chamber view we can detect the descending aorta, and here is clearly dilated.
It's actually even compressing the left atrium a little bit because there seems to be some degree of kinking.
And what about this patient? Do you recognize a disease?
I guess clearly there's a membrane right here, and this is aortic dissection. We've actually seen this case in the chapter on aortic regurgitation already. And what about this patient here? Well, do you think this is dissection? It would appear so because it looks like there's a membrane here, but in essence, this is one of the biggest pitfalls in echocardiography. This is not a dissection. This is just a reverberation artifact here from the front of the aortic wall. And for comparison purposes, look at the motion of this dissection membrane here, which moves kind of awkwardly and kind of desynchronous to the anterior wall. This is not the case here. So you could easily mistake a patient for having a dissection if you don't look into this finding. And finally, what about this aorta? Where's this view actually generated from?
Well, this is the suprasternal approach again, and it's not as clear to see as in the previous image, but still we have another membrane, maybe in the region of the arch involving the descending aorta. So another case of dissection. So this shows you the potential of echocardiography in diagnosis disease of the thoracic aorta. But should we cross the border of the diaphragm and go and see the abdominal aorta?
Well, Anna, I think this is a very good question. I mean, after all, we have a transducer in our hands, and even if it's not the abdominal transducer, we are able to visualize the abdominal aorta as well. So let me show you a case that highlights the potential of this. This is a patient I imaged quite recently with a dilated aorta. You see that the aorta is dilated, and then I did perform a subcostal view and kind of tilted downwards, and what I did see was this here. Clearly, this is a very dilated aorta and an aneurysm with a thrombus inside. So I think this definitely makes a difference in this patient. And if you look at the facts, first of all, an aneurysm in the abdomen is defined as an increase in the width to above 30 millimeters. But if these aneurysms rupture, and the risk is relatively high if it exceeds a certain diameter, then only 50% reach the hospital. And of those who reach the hospital, only 30 to 50%, or actually 30 to 50% die. So I think it definitely makes a difference to diagnose these, especially if you have high-risk patients. Still, this is not the main topic of our course, and we have a complete course on abdominal ultrasound as well. And I would highly recommend you to watch this course as well, and this is a topic that will be covered there, definitely. So we talked a lot about transthoracic echo. We still have one more modality to talk about, and that is TE. Anna, what is the role of TE?
Well, if you see these images, it's quite clear. Actually, this is a wonderful example of aortic dissection. And here we have a cross-section of the aorta showing really good the dissection membrane, separating the true lumen from the false lumen. And when we see the color Doppler, in this other example, we can actually see the blood going back and forth between the false and the true lumen. Sometimes blood in the false lumen could coagulate, and what you see is a thrombus. So all these findings together will be useful not only to make the diagnosis, but also to decide what to do with it for the patient. So just to sum up, know who is at risk, use all scanning views, measure and use other imaging modalities. And above all, when you see an aortic dilatation and you suspect aortic dissection, call for help.